Thank you all. The next segment, Clinical Pearls for Internists, Hyperthyroidism. May I now invite Dr. Roshan Lianage and Dr. Dilusha Lama Badusuriya on stage.
Good afternoon, everyone. Welcome to the final lecture of today's session. And it's a lecture on clinical pearls for internists. And it's my pleasure to introduce Dr. David Toro-Tobon. He's Assistant Professor of Medicine in the Division of Endocrinology at the Mayo Clinic. And he's going to talk to us about hyperthyroidism. Over to you, Doctor.
Well, thank you so much for the invitation. Thank you so much for having me today. It has been a wonderful experience so far. Really good talks throughout the day. Thank you for staying. I know it's been a long day. I hope over the last 30 minutes of this session, we really get to dive into the more important aspects of how to approach a patient with hyperthyroidism. And I really want to make this something very practical. I really wanted to try to bring some aspects of kind of errors or things that I get to see on a day-to-day on my clinical practice. So these are some real case scenarios that I get to see on a day-to-day. I am a consultant for Immunovant, but there's no conflicts regarding this presentation. And the learning objectives are to identify diagnostic challenges, discuss management strategies, and recognize complications and appropriate follow-up strategies for these type of patients. So there are some cases. I don't have the system to track questions, but just think about what would be your potential answer for a couple of seconds, and then I'll guide you through the reasoning behind potential answers. So first case, this would be a 30-year-old female that presents with a 2-month-old history of unintentional weight loss. It's around 10 pounds. She has increased sweating, heat intolerance, and frequent palpitations. She responds feeling anxious, occasional irritability, and poor sleep. She has some additional feeling of grittiness in the eyes, appears to be sleeping more than usual, anxious, irritability, poor sleep. On physical exam, she's having palpitations, heart rate is 110, diffusely enlarged, a smooth thyroid gland is palpated, and she has mildly exophthalmos bilaterally. Her labs show a TSH that is suppressed, less than 0.01, and free T4 that is 5. And long story short, you suspect this patient has Graves' disease. So relatively straightforward. Now the question is, what do you do to confirm this patient's diagnosis? What do you need to do before you start treatment in this patient? Do you do thyroid ultrasound? Do you do radioactive iodine uptake and scan? Do you check thyroid receptor antibodies? Or all of the above? And so the answer should actually be thyroid receptor antibodies. And I know some of you might have chosen all of the above, thyroid ultrasound, radioactive iodine, and this should be the reasoning behind all of this. Graves' disease is highly prevalent, happens 30 to 80 cases per 100,000 persons per year. It is the most common cause of hyperthyroidism, and it is more common in female, in those that are smokers, in those that are middle age, between 30 to 50 years, with family history of autoimmune thyroid disease. And as an autoimmune disorder, those that are affected have 99% of the times positive thyroid receptor antibodies. So if a patient has Graves' disease, it is highly likely that they will have positive thyroid receptor antibodies. As such, having positive antibodies should be enough in most of the cases to confirm the diagnosis. Thus, if we delay by time by waiting to have other results, we might actually just delay treatment unnecessarily. So, in normal circumstances, if you have clinical evidence of thyrotoxicosis, low TSH, high free T4, biochemical evidence of thyrotoxicosis, and positive thyroid receptor antibodies, you should have a confirmation of Graves' disease, and you should not need anything else before you can start treatment for Graves' disease. However, in some cases, their thyroid receptor antibodies are going to be negative. And in that scenario, then you should be able to do radioactive iodine uptake and scan in order to decide what the best next etiology is. And it could be that the uptake and scan is going to be low. In the case that it is low, what this result is telling you is that the thyroid gland is not overactive, meaning the reason why you have excess thyroid hormone is not because you have excess production, it's because you are spilling preformed thyroid hormone. So you're talking about thyroiditis. Now, if the radioactive iodine uptake and scan is high, it means that there is active production. If it's diffuse, then we're still talking about Graves' disease. It so happens that this is one of the very few percentages of patients that do not have positive antibodies, and it's most likely because the assays are just not catching them, not because the patient doesn't really have them. If it's patchy, it's toxic multinodular goiter, and if it's focal, it's toxic adenoma. So these tests, radioactive iodine uptake and scan, will help you identify alternative etiologies when it is not Graves' disease, or Graves' disease when it's not antibody positive. So you have the same patient, 30 years old, you confirm the diagnosis, you're going to be giving the patient beta blockers because the patient has a heart rate of 110, and you're going to define what to do for treatment of the hyperthyroidism. What do you want to do for her treatment? Do you want to do radioactive iodine? Do you want to do thyroidectomy? Do you want to do antithyroid medication? Or you can't really decide right now? And the answer is, we cannot really decide right now. We don't have enough information. And we'll tell you why in 1 second. Truth is, we used to use a lot of radioactive iodine in the past because we thought it was the best solution for the patients. It was a more permanent solution. That being said, most patients require thyroid hormone replacement afterwards, long life. On top of that, there's other complications that we're going to see. So the trend has shifted, and since now we're using more antithyroid medication for the treatment of our patients. Today, treatment of hyperthyroidism with Graves' disease, it's a shared decision making in which we need to account for the individual characteristics of the patient. And in particular, in someone like this patient who's young, who's female, who's in childbearing age, we need to balance pros and cons so that we can choose what is it that is best for our specific patient. There's some pros, there's some cons. For radioactive iodine, the pros include permanent cure. The cons include it requires lifelong thyroid hormone replacement. It requires radiation precautions, including separation from children and pregnant women after administration. It requires delay in pregnancy attempts, especially in a patient like her with childbearing age. It requires radiation side effects or implies radiation side effects. It might worsen thyroid eye disease. It cannot be given to a patient that already has thyroid eye disease. Antithyroid medication has some pros, low cost. It has a chance of sustained remission without prolonged or permanent hypothyroidism, but it also has some cons. Requires frequent monitoring every couple of weeks or months. Major side effects, it's possible to have agranulocytosis, hepatotoxicity, and vasculitis. There's also some risk of having fatal goiter, hypothyroidism, and congenital anomalies in pregnant patients. Surgery, permanent cure. Cons, requires lifelong thyroid hormone replacement, surgical risks, and high costs. So some pros, some cons, depends on what the patient prefers, what are the risks we're willing to assume. And again, in this particular patient, we have to balance the fact that she is female and she is childbearing age. So in this special population, there are some considerations that we need to keep in mind all the time, and that we should be going through any chance we are facing these type of patients. So if a patient is pregnant, we should not use radioactive iodine. That's contraindicated. If a patient is in childbearing age, we should avoid pregnancy for at least 6 to 12 months after radioactive iodine administration. And just keep in mind that after receiving radioactive iodine, there's some exposure precautions that include proximity to children and pregnant women. And these precautions vary in terms of time, depending on the dose that is administered, but it can be up to 23 days. So if the 30-year-old patient has 2 or 3 toddlers, this might not be the most feasible option. Or if the patient is a man, but the man has a wife who's pregnant and has a kid that needs to be taken care of, this might not be logistically easy either. So keep those things in mind, because logistically, this matters to the patients as well. Now, regarding antithyroid medication, and here, as I understand, methimazole is not available here, carbimazole is. Just assume this is kind of the same for practical terms. Propylthiouracil, you should be familiar with. So assume methimazole and carbimazole are interchangeable. Is associated with 2 to 4% of birth defects, especially aplasia cutis and choanal atresia. Propylthiouracil has less risk of birth defects, but higher risk of liver failure. So this is important to keep in mind, because depending on the stages of pregnancy, we might have to use one or another if we're going to use antithyroid drugs in patients that are going through pregnancy. So if you diagnose a patient with Graves' disease during the first trimester of pregnancy, you should start PTU and then switch to carbimazole after the second trimester. If you diagnose the pregnancy after the first trimester, then you should start methimazole. And then if you diagnose at childbearing age, you should diagnose methimazole and then switch to PTU 1 to 3 months before you try to conceive. And regarding surgery, if the patient's pregnant at diagnosis, surgery should be performed during the second trimester. Now, second case, 60-year-old male who was diagnosed with Graves' disease 2 years ago presents for follow-up. He has been treated with methimazole 10 milligrams daily with adequate tolerance and compliance. His labs at diagnosis included a TRAb level of 5, and his labs now included a TSH and free T4 with normal limits and a TRAb level of 3. So, long story short, patient with Graves' disease for 2 years, who's well controlled now, but the levels are still elevated. What do you want to do next? Discontinue antithyroid therapy, do radioactive iodine, do thyroidectomy, continue thyroid medication, or something else? And the answer here is you can actually continue antithyroid therapy. And here's the rationale. So when you have patients on thyroid medication, 30 to 50% of them achieve remission within 12 to 18 months of therapy. And this remission happens, or the best chance of remission happens, when the antibodies are negative. Now, when the antibodies are still positive, the patient still has a chance of recurrence after the antithyroid drug is discontinued. When this happens, when you have the antithyroid drug, when you have the antibody positive, and elevated, then you have two options. You can talk to the patient and say, let's keep going with the antithyroid drug, especially if the dose is not too high, because you're going to maximize the chance that the patient is going to go into remission. That's a very feasible option. Alternatively, you can consider doing radioactive iodine ablation or surgery, but the problem is then the patient will become hypothyroid and you're going to have to go into thyroid hormone long life. So you can still achieve some remission for the patient. It is safe. The additional rate of remission is probably around like 16% per year, up to 5 to 8 years. So I think it's worth giving the patients that additional chance of remission. It has been studied for up to 8 years. This patient has only been on it for like 2 years. So I would say if you have a patient that has only been on therapy for 2 years, give it a chance for up to 8 years, worth the risk, especially if it's a low dose. Case number 3, this is a 55-year-old woman that just moved to town. She has had subclinical hyperthyroidism for years. But she tells you that her prior doctor never treated her because her levels were never high. On review of her records, you notice that over the last 5 years, she had several TSH levels measured, all of which were less than 0.1. However, her free T4 levels and thyroid antibody levels were within normal limits. No additional thyroid-related has been conducted. She denies any thyroid-related symptoms. So we have a patient that has subclinical hyperthyroidism for several years. Would this patient benefit from treatment of her subclinical hyperthyroidism? And before you decide, just remember, 55 years old, so postmenopausal or perimenopausal, and her levels have been less than 0.1 TSH for several years. Would she benefit from treatment of her hyperthyroidism, subclinical hyperthyroidism? And the answer here is yes. She would benefit from it. Why would she benefit from it? Not necessarily because her subclinical hyperthyroidism would convert to overt hyperthyroidism. There is a chance that it could convert. In her case, clearly it hasn't. Free T4 levels have never been elevated. Estimating how much is the risk that it will convert is difficult. It could be anything between 0.5 and 8%. But the important thing in her case is that in patients that are older than 65 years old or that have persistently suppressed TSH less than 0.1, they have increased risk of atrial fibrillation, coronary artery disease, heart failure, and risk of fractures. And in these patients, they benefit from treating a specific etiology of their hyperthyroidism. But that's the thing. You need to know what's causing the subclinical hyperthyroidism. You cannot just go and treat whatever randomly. So in this patient, you had to go back. And while it was not obvious on the initial inspection, you did a thorough neck ultrasound, neck palpation, and you noted a large right-sided thyroid nodule. So you order a radioactive iodine uptake and scan, hoping to clarify the nature of that subclinical hyperthyroidism. And this is what you obtain. So what you're seeing here is a radioactive iodine and a scan. And on the right side, you're seeing that black dot. What that means is that there's a lot of uptake on that right-sided nodule. So the question is, what would be the next step there? You might be suspecting that this is a toxic adenoma on that right side. So suspecting that, what would you do next? Fine needle aspiration, antithyroid therapy, lobectomy, radioactive iodine, or radiofrequency ablation. This one's a little bit more straightforward. Answers are actually plenty. A lot of these are actually doable. The best strategy here, or the most common strategy here, is radioactive iodine, because the radioactive iodine that you give is going to go and concentrate in that nodule. It's very active, It's going to go there, it's going to burn it. The rest of the thyroid is going to be there intact. However, lobectomy is still an option. It's going to work. It's just that there's more risks associated with surgery. Antithyroid therapy is still an option. The problem is you're going to have to take it forever because the hyperactivity is never going to go away. But you could still use it, I guess, as a bridge. Final aspiration is not really needed because we know that since this is a hyperactive nodule, it is not a malignancy, it is not a cancer. At least the chance of this being a cancer is exceedingly low. And I guess the last option is radiofrequency ablation. This is the newest tool in the neighborhood. Radiofrequency ablation is pretty much you go with a needle, the middle of the nodule, and you heat it from the inside. You burn it from the inside so that it shrinks. This is the newest strategy, is the one that has been, we have probably the least experience with, but I think it is really promising as an alternative for these patients. And this is the last case. It's a 25-year-old female that has anterior neck pain, fatigue, exercise intolerance, excessive sweating, and tremors that began 6 weeks ago. Other than an upper respiratory infection 2 months ago, for which she had a sinus CT with contrast, her medical history is unremarkable. She is otherwise healthy and takes no medications. On physical examination, her pulse rate is 105 beats per minute, and other physical vital signs are normal. Diffuse standard goiter, no nodules are noted. No thyroid eye disease, there is a fine tremor of her outstretched hands, there is brisk, deep tendon reflexes. Her labs show a TSH that is suppressed, free T4 that is elevated 2.8, and a total T3 of 190. Urine pregnancy test is elevated. So we have some signs of thyrotoxicosis, some biochemical evidence of hyperthyroidism or thyrotoxicosis, and we have some neck pain, diffuse goiter. The question is, what is the most likely diagnosis in this patient? A, iodinated contrast exposure. B, subacute thyroiditis. C, Graves' disease. Or D, multinodular goiter. And in this patient, we're actually going to go with a B, subacute thyroiditis. What gives it away is the neck pain and the tender goiter. This is usually a viral process. It's triggered by a viral process. We have an initial phase of hyperthyroidism that is followed by a resolution that leads even to a hypothyroidism phase and usually recovers within a matter of weeks to months. For most of these patients, the only treatment that is needed is really pain management. In very severe cases where this pain is very severe, we use glucocorticoids as part of the management strategy. But really, the great majority of these patients do not need anything else. So most patients do not need antithyroid medication, do not need any sort of beta blockers for any sympathetic management. So really, most of these patients only need supportive care. Importantly, though, because this happens very frequently, there are many other forms of thyroiditis. This happens very, very frequently. And patients actually experience transient, painless forms of thyroiditis following very common day-to-day processes like flu-like illnesses, immunizations, or exposure to iodinated contrasts, many of which this patient actually has. She had a contrast for the sinus infection. She had some sort of flu-like illness. So things that our patients had on a day-to-day basis. And this happens regardless of prior personal history or of thyroid disease. When this happens, it's usually very mild and self-limited. Usually, when this happens, the thyroid tests normalize, abnormalities are usually mild, and it tends to normalize on its own. So I would encourage you, whenever you have a patient in which you have very mild thyroid abnormalities, always ask, was there any sort of recent viral infection, contrast exposure, anything that could explain this very mild abnormality in the labs that we're seeing? And if so, and if you do not have any strong suspicion of other forms of hyperthyroidism, it might be that this is just a very transient form of thyroiditis, in which case it's going to tend to normalize on its own without any need for treatment. And finally, this is just a bonus slide because we get far too many calls when we're at the hospital service. Amiodarone and thyroid like each other but hate each other. It can do far too many things, and it's far too complicated. We might need like 4 hours just to talk about it. But keep this in mind. Amiodarone blocks the conversion of T4 to T3. And as such, it is not uncommon to see very mild elevations in free T4 with no clinical implications and no need to adjust amiodarone therapy. In patients that are on amiodarone, free T4 can and will be slightly elevated, and that has no clinical implications. It's just because we are blocking the conversion of T4 to T3. That's no problem. It becomes a problem when we are dealing with amiodarone-induced thyrotoxicosis. And as you might remember, there's 2 types. Type 1 is hyperfunction. It happens as a result of the iodine component of amiodarone. It stimulates overproduction of the hormone. And there's usually some evidence of underlying Graves' disease, thyroid nodules, and there's high vasculature on the Doppler on ultrasound. And there's amiodarone-induced thyrotoxicosis type 2, in which case there's destructive thyroiditis. Now, whenever this happens, you're most likely going to want to have an endocrinologist working with you. And with that, just to summarize some take-home points, obtain only necessary tests and initiate therapy as soon as there is sufficient information to confirm the diagnosis. Tailor treatment to individual patient needs, carefully weighing clinical circumstances and patient preferences to choose an approach that best aligns with patient goals and current evidence. Manage thyroiditis appropriately, as common forms typically require only supportive care. And finally, recognize that subclinical thyroid disease is not always benign. Etiology-specific treatment may be needed in at-risk populations to prevent long-term complications. I want to thank you once again for the invitation. It has been a pleasure to be here with you today.
As we have already run out of time, we need to conclude. So on behalf of Sri Lanka College of Internal Medicine, I would like to thank Dr. David Toro-Tobon for his excellent and informative lecture on this common and important topic. Thank you.
May I invite my co-chair, Dr. Roshan Lianage, to present you with the certificate of appreciation.